welcome. This week, I'm filling in for Dr. Bird on our Ask Us Anything. For people who struggle with change, this is going to be a tough week because there is a ton of change happening incredibly rapidly. Omicron went from 2% to about 73% around the country. And we'll talk about how those numbers are figured out within less than 2 weeks. And it's beyond that likely now because the trajectory that it's on. So this is stuff that's changing rapidly. So today we're going to talk a little bit about Omicron. We're going to talk some about early treatment and also how that might be changing because there are a lot of developments that are kind of in progress that way. We're going to talk also a little bit about some data from Texas because, some people are skeptical of data from the CDC and some other places. So the Texas Health Department released their information, and Texas is relying pretty much on a trying to get people vaccinated strategy. Obviously, they're not doing much in the way of masking, at least as far as from a government role, and not a lot in the way of other mandates. They're encouraging vaccination, but they have quite a bit of data out about their rates. They also have some of how things changed with Delta, and there was some change, but still significant protection in many ways. So we'll talk about all of that. So let's start a little bit with Omicron. As I'm sure everybody's aware, it has been truly explosive, far more so than anything we've seen in terms of numbers. And it is clearly better about getting around antibodies. Our first line of defense is the standing antibodies that we have around. And whether we got those through infection or through immunization, it's clearly better at getting around our first line of defense initially. It does not seem at least nearly as much better about getting around T and B cells, our secondary immune response that we spin up, the response that we spin up significantly better if our bodies have been exposed to the spike proteins or COVID before. One of the wonderful things that our immune system has figured out is, over evolution over time, is that variants happen. And when we're re-exposed to something, our body tends to make variations in antibodies from what we saw before in anticipation that there might be some variants. So when we're re-exposed, we tend to make new and different antibodies. And that's one of the reasons we never ended up having a Delta-specific booster, is Delta had about 9 mutations on the spike protein, and there's about 66 epitopes that our body targets antibodies against. So we still had enough, and the ones that were uncovered, so to speak, our body was pretty good about making variations to cover that pretty well. So in terms of hospitalization, death, and long-term bad outcomes, we still had pretty good protection. Because Delta replicated so rapidly, it got a foothold up in the nose and the upper nasal passages that got things started, but generally not real sick. So if you're in the community and you're seeing other people get infected, it definitely seems somewhat discouraging. On the other hand, on the medical end of things, when we see what happens when things get really bad, we're still seeing that's very, by and large, people who are unvaccinated. I don't have full numbers. And I wish I did, and this is something I'll see if we can work on some better, but just a few numbers out of the local area. KSB has 7 out of their 8 patients in the ICU are unvaccinated right now. For us, it is 6 out of 6 patients unvaccinated. We have had people end up in the ICU who are fully vaccinated. The people who fail tend to be the people who are the people who are immune compromised, old, on chemotherapy, on steroids, things like that, or sometimes on dialysis, they have a tougher time making an antibody response. And the immunization is only as good as your immune system's response to it. It's not the vaccination that's fighting it. It's your body's immune response that's been primed by vaccination or sometimes by previous infection. That's the harder way to get immunity, but it is reasonably effective, and probably overall as good as fairly recent vaccination if you're fairly recently infected. What's clearly the best is getting both together, because then your body is re-exposed. You make more different sorts of antibodies to try and anticipate variants, and you're more prepared for them, and you tend to do better. So one of the things, maybe I'll get started with this this early. Rebecca, if you could pull up the vaccinated versus boosted. Yeah, we'll move to some of the other stuff. I know I'm getting a little out of order here, but I think this is really interesting. So this is a graph. This is on fully vaccinated and not boosted. That's that top blue line, or I'm sorry, the top blue line is the unvaccinated. Those are the numbers for the weeks ending on the dates listed. You can see that number, that line goes up very quickly. Below that is a darker blue line. That's fully vaccinated, but not boosted. That is people who've had 2 shots or one of the J&J. So they're significantly lower, but you can see those numbers were going up towards the end of November, or certainly in December, they've continued to go up some. And then people who were boosted, you see a small blip. They go up too, but certainly significantly less likely. And you can see the differences there. So while there is increasing relative numbers of breakthroughs, there's still proportionately less based on the amount of immunity that you have. And I would say that in general, you could correlate being previously infected with fully vaccinated and not boosted fairly well. And you could correlate hybrid immunity with the 3 doses. So if you've had infection and got vaccine on top of that, you're probably in the boosted line, or maybe even slightly better. That seems to be the best. So anyway, that's an important to understand, that nothing's 100% in medicine. And the outcomes that we really care about, the ones that really make patients suffer and that I have to see and follow up, are the people who end up in the hospital, and particularly ones that end up on high dose oxygen, heated high flow nasal cannula, the mask, CPAP, BiPAP, or especially intubated, or of course, if they don't make it. Those are the things that we really care about, is they change lives long term. You know, I see patients most every week who come in with an oxygen bottle, or they're on dialysis now, or they've had some complication. And what's tragic is these are often middle-aged people who were tough enough to survive and get through. They didn't end up in that 1 or 2% that end up not making it. They were young and tough enough to get through that, but they've been permanently affected and altered in that way. And we see quite a bit of that, unfortunately. I would say, in my experience, the typical patient that I'm seeing is someone who is middle-aged. They're convinced that they've made it this far, so they must have some special attribute or some special immunity. They think they've been exposed. They must have had it, but they've never been tested positive. They don't have any definite immunity, and they're not vaccinated. So that's the typical patient that I see go bad. And of course, they're very upset about, how did I get this far? I've done so well, and now I'm in trouble. And sometimes very significant trouble, because they're needing to see me in the hospital. So I guess that's the biggest message that I would get out. The people that I worry about the most are the people who are sure they're fine because they've gotten this far. They've gotten very lucky so far. It just hasn't broken bad yet. I worry less about people who are vaccinated at any level and people who have had some previous natural immunity. Those are both significant things in terms of the really bad outcomes. Certainly, as far as avoiding infection, being miserable at home, those are things that you want to avoid. That you want to get the best level of immunity, which means a booster or adding on to your natural immunity. So that's the different levels. All right, going back to Omicron. There's been a lot of talk about Omicron being less severe, and it may well be. The reason we have to hedge a little bit is there are a couple of things happening that are confounding that. In the data from South Africa, it's very young people, is one. And the other thing is we know that Omicron is very good about getting around our initial defenses. So it is infecting more people who are somewhat protected because they've had infection before or they've had immunization. So they have some level of protection. They can spin up that secondary immune response, but they're now getting infected. So they're a case, but they don't get as sick. So what's not clear yet is that it's milder for people who don't have protection. So people who aren't immunized, haven't had a previous infection before, a definite infection. Again, I see a lot of people who think they might have, they were sick at some point and they think they might have, but they were never sure, never tested. And it turns out they weren't protected. And they're the people that I often see. When Omicron infects people who have some protection, those people are definitely less likely to end up in the hospital and less likely to be dead. And since Omicron is infecting more of those people, it looks less severe. But that's in part because it's better at getting an infection going in people who already have some protection. Again, I don't know, and I don't think there's good data on yet. Is this less severe for the person who has no protection? The person that we worry about the most, the people who are getting into the most trouble, is Omicron less severe for that? I don't think we can say that yet. We know it's definitely more infectious. It's definitely coming for everybody. I mean, in a hurry. This has been very, very different that way. All right, so let's get back to local data a little bit here. I kind of skipped this, so let's get back to our local rates. Rebecca, if you can pull up that graphic. All right, so the Whiteside County weekly update. You can see pretty much when our wave got bad pretty darn quickly here. You can see those cases in the last few weeks here have really taken off at a very high level. Went from 79 to 106 to 281 to 323. That's obviously really worrisome exponential growth. Now, a lot more people are protected. So while the hospital is stressed, it's not quite as bad as it was in November because we don't have all the elderly people without any protection and having waves of nursing homes come in and that sort of stuff. So if Omicron came first, boy, I think we would have been completely overwhelmed and in a kind of third world situation. But because there's a fair amount of protection out there, there's a ton of cases and significant stress, but not quite overwhelming. And we hope it doesn't get there. That's what we still don't know. But so looking a little bit more, you can see on the bottom right, those cases going up real quickly as well. It seems like maybe there's been a little bit of leveling in cases, but it's not really enough to certainly call a trend yet. You can see our previous Delta wave never really went down before it got here. You can see our positivity rate continues to climb some, and case counts remain pretty high. So the other big question that comes up with that is Omicron here? And boy, that is tougher information to find than I think it necessarily should be. In digging into that a little bit, I've learned that we submit 15 cases per week to the state for testing to see what the general trends are. Those get sent into our region's database, and that comes back to what our region is looking like. And that data comes out a few days later. With as fast as Omicron is going, it's really not keeping up. And it would be really nice if we would know, especially from patient to patient, who has what, because this is a case with Delta, there really wasn't much difference in treatment. There may be difference in treatment, and we'll get to that in a little bit about what you do with a Delta patient versus Omicron patient. This is obviously evolving very quickly, but there's some data to say we may need to think about things that could be different. So hopefully that data can get more real time. What I do have, Rebecca, if you can pull up the nowcast on Omicron. This is a few days ago, but this is that collated data. So our data for locally is lumped in with that, but we're region 5 in there. And if you can see, the purple is Omicron. So already as of a few days ago, our region was highly Omicron out west and more into the west of the Midwest. It hadn't gotten there fully, but this is far faster than Delta went. So this is a very big change. So statistically, I would say it's most likely that if you're getting COVID in this time, it's likely Omicron. But we don't know on an individual basis. We can't sequence do all the genetic sequencing for every case at this point. So that brings me to, let's talk a little bit about early treatment, because there's been a lot of interest in that, and there's a lot of feeling that that's not done a good enough service. So I want to make sure we address that pretty comprehensively today. So the first thing I would say about early treatment is it's critical that it's really early, because oftentimes that I see is the people who don't really want to. They're not engaged with medicine. They don't particularly want to get vaccinated. They also don't want to seek care when they're sick very quickly. And when it's just cold symptoms or minor, it's understandable, but they just want to wait it out and see what happens. And what we see is then they present at day 7, 8, 10 when they're really sick, and the window is either closed or closing on things that we could have done earlier. So and we also see a lot of bad outcomes in terms of people still holding public parties and weddings and other events and big things when they're just a little sick. And I get that. Normally we it wouldn't be such a big deal, but we certainly we've seen, and we currently, we have patients in the hospital that were involved in super spreader events that seem to be related to that. And so if you are a little sick, it's probably a cold, sinus stuff like that, just get tested. There's rapid testing at Walgreens. There's multiple different places we can go. The hospital website has some links on that. Rebecca can put up some stuff on that as well at the end. But just get tested, because you got to know. Once you know, please contact your doctor, because everything else comes from what are your risks, what's your contraindications to treatment, what's your specifics, how can we make it work or not work for you. So when you contact your doctor, if I have a patient that's positive, we do a telehealth visit, and we almost always try and do it the same day, or at least at a minimum by the next day. And we talk through your specific issues and what we can do for you. Up through this point, the mainstay of early treatment has been monoclonal antibodies. And let's talk about what that means. Mono is one, clonal is one clone or type. So basically, the scientists have isolated certain highly neutralizing antibodies, and they've mass produced them. Mono meaning it's one type of antibodies. Oftentimes we mix two of them in, like Regeneron, the one we've been using now, is a mixture of two antibodies. They highly target one of these epitopes or little areas on the spike protein that we're trying to get at. And with alpha, and to a pretty good extent with delta, those areas were not mutated that we were targeting. And monoclonals, if we got them started early, Now, they can be done within 10 days of the onset of symptoms, but they sure work a whole lot better if they're in the front half of that than in the back half of that. And they had about a 70% reduction. Now, I said had because there is unfortunately pretty good data that in Omicron, it has 30 some mutations. It's got a ton of mutations. And because it's changed so much, those specific areas that the monoclonals we're looking at have often been mutated, and it looks like monoclonals aren't working as well for Omicron. Doesn't mean they don't work at all, but it's significantly affected. And there's only one of them that seems to be somewhat better that way, and it's in pretty short supply. And it's the federal government has already sent it out to the highest Omicron areas. So that's going to put a significant dent in our ability to work with monoclonals. But I would still say contact your doctor. This is a rapidly evolving thing. We've got to keep up on what we should do. And I'm not saying that's hopeless. It's just not nearly as good as it was with Delta. All right, moving on to some of the other big news. You've probably seen the two medications from Pfizer and Merck, I believe, Paxlovid and Molnupiravir. Let's talk about Paxlovid first because it just got approved. This is really big. This works a little bit similar to some of the other antivirals we've used for flu, but it seems more effective yet. It targets some enzymes that the virus has to use to reproduce, and it seems to be quite highly effective. And people who are high risk, it decreased the rate of hospitalization and death by 88 to 89%. That's really impressive. But in the study, you couldn't get in unless it was early. You had to be in the first 5 days, and they tried to do it as early as possible. It seemed to decrease the risk of hospitalization and death about 70% in lower risk people. If you're lower risk to begin with, it's harder to improve those outcomes. They're already better. So for high risk people, that's huge, and it's just been approved. The rub is we have a huge need evolving right in front of our eyes, and only so much to go around. I mean, they've ordered a lot of doses. There are some that are pre-done. And we'll have to see about how availability works out and how that's going to be done. I don't believe that we can get this as of today, but it should be hopefully soon that we can get some. All right. We'll have to keep you posted about when we know more about that. But for high risk people, if it's something we can do, that's impressive. The other one, Molnupiravir, it works differently in that it takes some of the genetic building blocks that the virus needs to make new copies of itself, and it inserts kind of faulty copies, Trojan horse copies with that, until it induces so many mutations that the virus becomes non-functional. It looks like that's about a 30% reduction in hospitalization. And that's not yet approved because there are still some potential concerns about what does that mutation do. It's been used elsewhere in HIV and seems to have good safety there. Not this particular drug, but a similar strategy. And it may be promising. There's also a lot more of it around. Merck got ahead of this better and they made a lot more. So it may be a lot more widely available. But again, it's not yet approved. And there are some concerns that if there's other things that are rapidly replicating, like in pregnancy, that you could potentially take up some of these faulty blocks and cause some problems. So there'd be some limits to its use. And there are still at least some potential concerns. And this is what's being sorted out about getting approved. So moving on, there was a couple of trials for pre-existing medications, ones that we already have that we're trying to repurpose. So I'm sure we've all heard about hydroxychloroquine. That was the first one we tried to repurpose. Unfortunately, that did not pan out, and that's pretty clear at this point. Ivermectin was another one that showed a great deal of interest. There were some small studies, particularly in the Middle East, that were hopeful. One of the interesting things, and this is how context matters and the nuance of science matters. In Egypt and Iran and some of the places that these smaller studies were done, we see a high rate of silent parasitic disease, sometimes as high as 50%. Now, you take someone who is living with a low grade of parasites and you give them COVID and you put them on steroids to treat their COVID, and these parasites go wild, so to speak. They start to cause a lot of trouble. And if you put those people on ivermectin, they get better, but they get better because you're treating their underlying and now uncovered parasitic disease that's gone wild because you're sick and you're on steroids, which unmask them. Not necessarily because we're improving outcomes with COVID itself. There were a couple of big trials done here that were pretty conclusively negative. There's still a few niches that are being looked at, and it's not 100% positive that you wouldn't find a niche, but the effect almost certainly would be small. The idea that this is a miracle, unfortunately, is clearly not the case, and it's not clear whether it'll have a niche at all. But we remain hopeful that the remaining specific timeframes and situations might still find a niche to put it in somewhere. But it is also clear that that we can cause some harm with this. I know people say it's been around for a long time, it's been safe, which is true. But in the context that it's been used, it's typically used as a single dose treatment for parasitic disease. For COVID, you have to use high doses and for a long period of time. It's a medication that sticks with you for a long time. It builds levels. This is a very different situation than giving it once. We've seen liver function studies go up and people with this and some other things that are concerning. So we just need to have some respect for this is a different situation, and we shouldn't just throw this at people hoping for the best. That's not good medicine and not supported, especially at this point. If there is something the one that did come out of a couple of repurposed drug medications, well, the first one I should say is dexamethasone. That was the first big one that came out and is the mainstay of treatment. It's a cheap drug that was repurposed. It works significantly well at decreasing bad outcomes once they get really bad, once you get into the second inflammatory phase of COVID versus the initial viral phase. You don't want to take steroids while the virus is really actively replicating in the beginning, but once that phase is coming down and you're into this inflammatory cascade, then they're definitely helpful. But the next one that's emerging and becoming promising is Fluvoxamine. It's an antidepressant, so it has the potentially helpful side effect of maybe helping you feel a little less sad about your situation. But significantly, it seems to have some positive effects throughout the course. Now, this data is fairly early. This it should be a full disclosure. This is not yet standard of care. This is something that's interesting, and you should talk to your doctor about. But in the interest of talking about stuff that's new and interesting in early treatment, Fluvoxamine has the Active 6 trial, where they looked at 6 different options, including ivermectin, hydroxychloroquine, and a few other medications. It was the one that showed superiority and graduated on to a bigger trial. So it's still in the bigger part of the Active 6 trial. But there was also another pretty good sized study out of McMaster University, and it was run out of Canada, actually done in Brazil, that showed pretty good evidence of early improvement with Fluvoxamine. Fluvoxamine's less than $10 for a course, and so it's promising. But that's the most I can say. Again, talk to your doctor about what promising means for you, and so that's definitely definitely something interesting. Okay, so that's a lot of what I wanted to talk about with regards to early treatment. Oh no, there are a few other things. Vitamin D. Vitamin D is important in immune function in general. It's pretty clear that people who are low in vitamin D tend to do worse in terms of respiratory illnesses in general, whether that's because people who are low in vitamin D are also unhealthy for other reasons, or from vitamin D is a little less clear. And it seems to be fairly clear that big doses of vitamin D right when you get sick don't turn that ship around. But it seems very reasonable to supplement vitamin D for most people in this region. Just in general, we don't get a whole lot of sunlight in the winter. Sunlight is how we make vitamin D. Many of us are vitamin D deficient, especially if you have darker skin in the winter, and supplementation is likely helpful and certainly a good idea. A few other little things. Making sure we're taking care of ourselves in this time. All right. We're all stressed, but getting adequate sleep, prioritizing that, getting adequate exercise, whether you're vaccinated or not, your immune system is playing a big role here. And if your immune system is not in good shape, vaccination can only help you so much. And the people that we're seeing break through often are the people who have, are at risk for immune system problems. So don't just rely on vaccination and not take care of yourself. It's really important that you do those things. And fitness matters, sleep matters, trying to manage stress. You're going to have to say no to some people. So, and some things, and kind of just being good to each other. Boy, there's a lot of stress that's coming out in negative ways. And that does not help people get through this time or infection if they get it. So let's try and be good to each other out there. Okay, so a couple last things. Rebecca, if you can pull up the other number, the graph 2 out of Texas, I'd like to share a little bit more of the Texas data. So this shows, this is data out of the Texas Health Department, and the dotted red line is people who are vaccinated, and the blue line is people who are unvaccinated. So you could see at the peak of the surge there, and this is in Delta, all right, the death rate, now this is not the infection rate, and we'll get to that in a moment, but the death rate was 20 times higher in people who are unvaccinated versus vaccinated. And this was true across all age groups, even young people. Now, young people don't die very often from anything, but the ones that did were far more likely to be unvaccinated. In fact, the younger you are, the bigger percentage benefit, because your immune system works better. So it responds to the vaccination more robustly, and it gives you more relative protection. So percentage wise, the younger you are, the more benefits you gain. Now, you're taking a fairly small number down to a tiny number, whereas with older people, you're taking a very big number down to a less big number. So in raw numbers, old people benefit better, but in percentages, young people have a bigger percentage response. And this is in Delta. It was more than 45 times higher when we were in Alpha, but even through Delta, we saw 20 times higher protection rate. So with Omicron, obviously that the final data there is still pending, but it does look like we still get a good secondary immune response, because remember, that doesn't depend only on the antibody sites that have been mutated. That also depends on T and B cells, which are much more flexible and durable and deal with variants much better. So while you can still get into trouble in any situation, people say, well, I could get vaccinated and I could still get sick, I could still die, I could still do all those things. That's definitely true, but the rate at which those things happen are dramatically different, right? People who are sober driving crash and die, and people who are drunk driving crash and die, but they don't do it at the same rates. And there is a very different rate when it comes to the bad outcomes. And for me personally, all of the bad outcomes I have seen in terms of in my own practice, people who ended up on long-term oxygen, people who ended up disabled, they can't work anymore, people who ended up on dialysis, people who need lung transplants. Every one of those people who had the terrible outcomes, people who ended up on ventilator, were all unvaccinated. I've personally had one person who was fully vaccinated be hospitalized, and they did well. Now, my experience isn't universal, but it's pretty reflective of the differences that we see that way. All right, so let's look at the raw numbers. I think the raw numbers are interesting, and then we'll move on to questions. So, okay. I just got confirmation on our own ICU numbers. When I asked the nurse, they pulled it off the top of our head, but we do have confirmation that nobody in our ICU right now is unvaccinated. Is vaccinated. Everybody who's in our ICU, everybody who's ventilated, is unvaccinated, unfortunately, which means that and this is the tough thing for us to see, is that statistically, 80-90% of that was preventable, but only if you get ahead of it. And this is happening to young people. I mean, we've these last few weeks, we've had people in their teens hospitalized, and we've had people in their 30s who are otherwise well, intubated and in trouble. So that's hard to see. Those are things that we've got to try and do better on, so that nobody thinks it's going to be them, and certainly the people who ended up here didn't think it was going to be them. But in terms of bad outcomes, it's still really critical. So, all right, so let's move on to, this is again from the Texas Department of Health. If you look on the left, there was over the course of the entire COVID season, so to speak, they had 1.5 million positive infections. This is the time since vaccinations have been available. This isn't from the very beginning. Of those, 1,300,000 were unvaccinated. Partially vaccinated were 184,000, and fully vaccinated were 46,000. Now, 46,000 is still a lot of people. Everybody's going to know somebody who had a breakthrough case, and those numbers are probably going up. But there's still a significant predominance towards people who are unvaccinated having worse outcomes. Now, in your own circle of friends, that may vary. Randomness plays a role here, but in terms of big numbers, there's a very clear trend. And moving over to deaths, Texas had 28,659 deaths. Unvaccinated were 24,517. Partially vaccinated were 1,942. And fully vaccinated were 2,200. So yes, that does happen. Fully vaccinated people have died, but at a far lesser rate. It's also interesting to look. The average person who was infected was 39 years old. The average person who died was 67 years old. If you look at the breakdown, this on the right side, you'll see 75 plus was 35%. People who were 65 to 74 were 25%. But that leaves 40% of the people that died were less than 65 years old in Texas. That's discouraging, because those are people who were had a lot of life left to live, and also people who almost certainly would have responded well to vaccination because they're young and they have robust immune systems that would make that response. So that's that. All right. Well, let's move on to some questions. We're about 40 minutes in, so let's take some questions. All right, Jasmine Fitch, should vaccinated people also test regularly since they may not know they're infected? Yeah, so this is something, I'm going to draw this out. As far as testing regularly, I think you should be careful to test if you're going into a high-risk situation. I don't know about testing regularly all the time if you're not in a high-risk situation, but if you're going to take a trip and you're going to see someone who is high risk, I would think hard about doing that. Yes. I'm going to draw out a graph here with, and I'll show it to the camera here in a moment, with what happens with vaccinated and unvaccinated people as far as what happens with their viral load over time. So here we go. So let me try and get it in the middle. This is the viral load, and down here is time. If you're vaccinated, you still often develop a high viral load, but you clear it very quickly. That's why this line comes down very quickly. I didn't have enough space, but people who are unvaccinated tend to clear their viral load a lot more slowly. They don't spin up their secondary immune response. So if you're a household contact and you're seeing somebody every day, you're likely to see them in this range when they have the high viral load, and you're still somewhat likely to infect them if you see them every day. If you see somebody further down, let me get back to this. If you see somebody, everything's mirrored here, so I'm trying to work that out. But if you see somebody at this point, you can see there's a big difference in the viral load at that point in time from the top graph to the lower graph. So if you're working with somebody and they're a day out from their maximal viral load, their viral loads are going to be very different if they're vaccinated or unvaccinated. So that still makes a difference. And keep in mind, in order to get into this test, you first had to have a breakthrough case. So you're selecting out a population that's already broken through the vaccine.